Good afternoon, everyone. I thank APOS, Dr. Gopal Rajgaru, the Scientific Committee Chairman, Dr. Sudhakar sir, for giving me this opportunity to speak a few words on corneal biomechanics, which they gave the tough topic in 5 days. I could make out very brief, like the topics covered are very briefly on some basics on biomechanics, the strength of cornea and the anterior half of the thickness, how the LASIK flap, its position, the hinge influence on the dry eye. So the corneal biomechanics, this topic is like it's below the tip of the iceberg. Like if we see the topo and tomo, which is above the iceberg, in refractive screening is done to separate the abnormal corneas from the normal ones. In downfill bad, the integrated Corvis pentacam helps as an adjunct. So here the corneal biomechanical properties are actually what we see are they're more than the what we see above the tip of the iceberg. So here both the Oculus pentacam and the Corvis ST both they just have to have a look together. So briefly about the some part about the theory. According to Cynthia Roberts, the cornea is not a piece of plastic. It is both elastic and viscous. Elasticity is a property of a solid where it describes ability of the body to resume its normal shape after deformation. Whereas viscosity is a property of a liquid which describes resistance against permanent deformation. And stiffness is the actual force needed to elastically deform the body. It is the actual rigidity of the cornea. And the stiffness is dependent on several factors, where the biomechanics depends on the material, the thickness, and the internal pressure. If we take a small example, there's the football which deforms not easily, whereas the other ball which deforms easily. So ABC, it's a quick revisit tomography where we have to look into the anterior surface, the back posterior surface, and the corneal thickness. And adjunct to it, we have to go for the biomechanical factors by Corvis ST. So the assessment of corneal biomechanics in vivo is still evolving. It includes CH, that is corneal hysteresis, and corneal resistance factor sensitivity and specificity, which is low to differentiate keratoconus from normal corneas. Before, ocular response analyzer was used, where the CH, that is corneal hysteresis, was measured using difference in the applanation pressures on the inward and outward pressures in the dynamic applanation tonometry, whereas its sensitivity and specificity are around 78 and 63%, and CRF is also not so valuable. It depends on the CCT and the AT. In this role of Corvis ST comes, it's a biomechanical assessment tool in modern refractive surgery. It uses the real-time corneal deformation data to analyze corneal biomechanics. It optimizes ectasia detection using some indices where we take CBI, SSI, TMI, and BIOP as the main things. Here, 30 milliseconds air puff is used to define and record the corneal reaction. It uses a high ultra speed Schimflug camera, which gives about 4,300 frames per second. The Corvis ST measurement display has got these 4 display measurements: Vinci Gura screening display, integrated display, and the comparative display. So overall outlook, I'll be just saying about the practical indices which we have to take into account. This is CBI, that is the Corvis Biomechanical Index. Its normal value should be around less than 0.5. It is based on the corneal thickness profile and deformation parameters, where algorithms are used by the manufacturer to give the value. So some part about the theory of it is a deformation amplitude, where it measures the deformation of the cornea at the apex and then 2 millimeters away from the apex, where the softer cornea starts to deform quicker, deeper, and over a wider area, whereas the paracentral cornea deforms much lesser than the central area. So the softer cornea will have a higher index value than a stiffer cornea. The other parameter is about the stiffness parameter, where stiffness is the ratio of force by displacement. Here, air pulse at the cornea, difference of biomechanical IOP gives a force. Here also higher index value is for the softer cornea and lower for the stiffer cornea. Integrated radius, it also takes into account where small softer cornea deforms more rapidly over a wide area and steeply, so that the radius of curvature is steeper and the area subtend within that is larger. The same thing is for the higher index value is for a softer cornea. Another index is a tomographic biomechanical index. It is a most specific index. It's better detects the subclinical keratoconus where artificial intelligence nomograms have been used to calculate. The other index is a stress strain index, which is approximately equal to 1. It is actual rigidity. It gives the rigidity of the cornea. It includes both geometric and intrinsic material stiffness, and stretching factor. It gives its numerical values to stiffness. Normal value around 50 years of age patients is around 1. If it is less younger patients, it will be softer, less than 1, and stiffer if it is more than 1. Now, if the display, if it is, it looks like this. So here, these two come under the indices, and the inferior superior, these come under pentacam, and bad D should be less than 1.6, and CBI index should be less than 0.5, and TBI should be 0.29. So these three indices we have to correlate to differentiate between normal topo and abnormal like ectasia. So some case scenarios, if you see, it's a 23-year-old male patient who has the topo central thickness of 522 microns in the right eye with normal anterior and posterior elevations, and the bad D is around 1.48, which is quite normal. Here the CBI is more than 0.5, it is abnormal. Even TBI is also abnormal. The same is the case with the left eye also. To summarize, the pentacam values, the bad D were quite normal, whereas CBI and TBI were abnormal and borderline. So this guides us to avoid any corneal refractive surgery as the chance of ectasia is more. This is another example, same 25-year-old male patient with normal, absolutely normal pentacams with 509 microns with anterior and posterior elevations normal. But here the bad D is also normal. The CBI index around 0.5, which is a borderline, whereas this TBI is quite less than 0.29, which is normal. The left eye is also looking the same. To summarize, this patient has got a CBI borderline in both the eyes, bad D is borderline in one eye and normal in other eye, but the TBI, this index is normal in both the eyes, and the SSI is less than 1, so softer. So bad D and CBI values are borderline, TBI is normal, so the patient was advised with both eye surface ablation. This case is a third case of a patient with no family history of keratoconus, but at 489 microns a Pachy and asymmetric bow tie on the refractive maps with both the CBI around 0.62 abnormal in both the eyes, and TBI is around less than 0.29, that is 0.23 borderline in both the eyes. Since CBI abnormal and TBI is borderline, though the bad D values and SSI are normal, the patient was kept under observation. So if we take the clinical significance of corneal biomechanical changes, they help in the assessment of accurate intraocular pressure. It helps to detect detection of subclinical keratoconus, monitors progression efficacy of CXL, and prediction of refractory outcome of corneal surgery. If we take the other parameter of strength of cornea on the anterior half of the thickness, the anterior stromal interval is a chief architecture determining the differential swelling behavior of the stroma. They suggest that it is responsible for the structural stability of this region of the cornea, which is important in refractive surgery in conditions like keratoconus. As we go for deeper ablations, there is a more chance of ectasia post-LASIK. Basics of corneal nerve supply and distribution, they form through the nasociliary branch of the trigeminal nerve. They enter the cornea through at the 3 o'clock and 9 o'clock positions, and they form a subepithelial plexus. So during LASIK, when because of flap formation, there will be denervation of the corneal nerves. So the reflex arc of tear secretion is disrupted. So post-classic dry eye occurs around 3 to 59% of the patients. Apart from the denervation, there is also damage to the goblet cells by suction ring induced pressure. And there can be a neurotrophic component with decreased corneal sensations and blink reflex. So there can be altered tear film stability caused by changes in corneal curvature. There can be some pre-existing dry eye also with medication induced effects. So all these effects can cause a post-classic dry eye, which we can measure with Schirmer's or T-BUT. There are some studies which some hypotheses have been said. The long posterior corneal nerves innervate in the cornea, enter the eye at 3 and 9 o'clock positions. Therefore, according to this study, when there is the superior hinge flap, when there is more of denervation, there is more loss of corneal sensations that results in a greater dry eye syndromes, because both the nasal and temporal corneal nerves have been denerved. Whereas in a nasal hinge flap, only the temporal corneal nerves have been denerved, and the nasal preservation of the nerves have been said to have caused less dry eye. This usually at the end of 3 months, this difference comes between nasal and temporal, nasal and superior flaps, where nasal will have less incidence of dry eyes. But at the end of 6 months, actually the incidence of both the flaps have been, there is no significant effect on hinge position on corneal sensation or dry eye parameters at the end of 6 months. So aggressive dry eye regimens are needed for patients with preoperative dry eyes. And there's an interesting one more paper which suggests that the effects of flap diameter on dry eye parameters and corneal sensations after femtosecond laser assisted LASIK. Here they say that the cutoff value for the flap diameter was 8.7 millimeters, and that is the dry eye is more affected with the ratio of flap and corneal diameter ratio. So the surgeon should keep this effect in mind when customizing the corneal flap sizes for dry eye patients during LASIK. So to go for a take-home message, the corneal biomechanical metrics can be used as an adjunct to tomography in refractive surgery screening. Corvis ST definitely provides an edge over conventional screening for refractive surgery. Hinge position has no significant correlation on corneal sensation in dry eye, at least after 6 months, and flap and corneal diameter ratio has to be kept in mind. Thank you.